Dear colleagues, ladies and gentlemen, welcome to the view from the Thoraxcenter for Radcliffe Cardiology. This time we review AHA 2023, and in this wrap-up we will highlight 5 late-breaking clinical trials. My name is Nicolas from Mieghem. Next to me, as always, my good friend and colleague Joost Daemen. Joost, let's start with the DAPA-MI.
Yeah, so not too many trials, but indeed 5 important trials that I think that make sense for all of us as cardiologists and not just within the interventional cardiology field. So the first trial we would like to highlight is the DAPA-MI trial, which was a large, big, randomized controlled registry-based trial from the UK and Sweden, testing the hypothesis whether Dapagliflozin was superior in terms of reducing adverse cardiovascular events in patients post-MI who did not have diabetes and who did not have congestive heart failure. So this would really entail an expansion of the indication for DAPA at this point in time. So a very interesting concept in a drug that we know actually lowers also high sensitivity CRP, reduces inflammation, and may even result in superior outcome in patients post-STEMI. So almost 4,000 patients were randomized 1-to-1 to Dapagliflozin or placebo within 10 days after acute coronary syndrome. So that entailed both STEMI as well as non-STEMI. Follow-up had to be for a minimum of 3 months, and the study was initially designed for a primary endpoint being all-cause cardiovascular mortality or hospitalization for heart failure at a minimum of 3 months. However, what happened is that during the course of the trial, the event appeared to be significantly lower than anticipated, which drove the investigators actually to change the design a little bit and also incorporate somewhat softer endpoints like new onset AFib, diabetes, weight gain or weight loss, and cardiometabolic outcomes in general. And changed this design to a win ratio design, which changed a little bit the statistics and the final message I think that the trial brought us. So on average, patients were at the mean age of 63 years, 72% of patients presented post-STEMI. And then for the primary endpoint, the win ratio was 1.34 in favor of Dapagliflozin. That meant 33% wins for DAPA, 25% for placebo with respect to the primary endpoint. For the initial endpoint being CV death or hospitalization for heart failure, 20 versus 17 wins, both highly statistically significant. And this benefit was very consistent across each of the pre-specified subgroups without any safety concerns. So far the new primary outcome of the trial that was simultaneously published in New England. Several concerns though. So if you look at the primary endpoint being CV death or hospitalization for heart failure in terms of absolute figures, we are looking at an event rate of 2.5 versus 2.6%, which was way lower than anticipated, and obviously also not far away from reaching any statistical significance. The investigators comment on that if we would have repowered the trial based on these event rates, we would have needed over 20,000 patients, which is perhaps somewhat too far-fetched to be realistic. Then, second thing, the positivity was driven mainly by reductions in weight loss and new onset of diabetes. But again, in absolute figures, 1 kilogram weight difference, 2% difference in new onset diabetes. So not really figures which make you think, wow, that's an impressive effect. Moreover, finally, there was discussion on the inclusion of patients with non-STEMI, which is obviously a little bit of a different entity as compared to STEMI patients. So somewhat critical reviews during the session, but that said, I think overall a positive trial, but I'm not sure whether this will quickly change our guidelines.
I have some issues with how the study was eventually conducted. You know, this change of primary endpoint, you first have a composite endpoint restricted to hard clinical endpoints, and then all of a sudden you add new onset diabetes and a change in New York Heart Class and even weight loss, and these are soft endpoints. So, and they did an interesting analysis. So in this new primary endpoint, which was a hierarchical endpoint of 7 components, then they looked at the same endpoint but then only included 6 components. So they dropped the weakest one, if you will. And then at 5, at 4, at 3, at 2. Well, the moment they dropped to 5, it was no longer there was no longer a difference between the 2 treatment arms. So, you know, from a hard clinical endpoint point of view, this was a negative trial.
Yeah.
This was a negative trial, so I don't think this trial is gonna change our practice at this point in time. And obviously, we were looking for yet another massive indication of SGLT2 inhibitors, and I was a believer. I am still a believer that these are very powerful heart failure drugs. But in the context of acute MI, I don't think we have strong evidence now to support it.
It's an interesting discussion. As with most of the trials we will present. I mean, you are absolutely right. Conversely, I mean, we are now at a stage in which we are no longer able to improve outcomes in STEMI with antithrombotic therapy. We're no longer able to improve outcomes with shorter door-to-balloon times, with a better stents, for instance, less stents, using physiology, using imaging. I mean, there's little benefit to be gained, and now with all these soft endpoints, which we know are linked to long-term heart clinical endpoints, this is what we have. But I agree with you in terms of absolute endpoints.
But there's one thing to look at endpoints, but it's another thing to add weight loss and new onset diabetes as an endpoint. Combined with these hard clinical endpoints, right? So that it becomes artificial to me in a way.
And by the way, maybe that was the reason that this paper was not published in the main New England Journal of Medicine, but in the subjournal called Evidence.
Exactly, and it makes sense.
Yeah, I agree.
Okay, let's go to Orbita 2, because that one was published in the New England Journal.
Yep. So Orbita, you recall. So Orbita 1 was designed and published 6 years ago, the trial that actually failed to show a superiority of PCI on top of optimal medical therapy in patients with stable angina undergoing PCI in terms of quality of life and treadmill testing. Now, Orbita 2 was designed. I think the investigators learned a lot from the renal innovation trials that were recently published, in the sense that, again, they designed a sham-controlled trial in which both patients and physicians were blinded to the initial treatment allocation. Patients were taken off their antihypertensive drugs in the 2 weeks prior to their intervention, and then were followed for a 12-week follow-up period for a primary endpoint being anginal episodes at 12 weeks. So basically 439 patients were enrolled who had to be on with or without antihypertensive drugs. They needed to have angina. Most of them at the end were in CCS class 2 or 3. They needed to have significant coronary artery disease, being either single or multivessel disease as confirmed by angio or CT. There needed to be evidence of ischemia, and as mentioned, they were taken off their guideline-directed medical therapy. So finally, 301 patients were randomized. Virtually 100% was in CCS class 2 or 3, and 80% had single vessel disease. And then the primary endpoint was reached in 2.9% of the patients in the PCI arm versus 5.6% in the in the control group, I should say, reaching a statistically significant difference in favor of PCI, mainly driven by a significant reduction in the PCI arm of daily angina episodes. So basically, patients who had PCI were 3 times less likely to be free of symptoms as patients in the control arm. So with that, a interesting trial proving the concept that PCI actually works in order to relieve angina in patients that were taken off their antihypertensive drugs. Conversely, the trial still raised a lot of debate. 60% or 58%, if I'm correct, still had anginal symptoms. We still face the challenge with this number that it's very difficult to apparently predict who will benefit from PCI. My take, however, is that we learned from Orbita 1 that drugs work, and in Orbita 2 we learned that PCI also works in terms of relieving angina. Conversely, we also know that drugs only work in patients who actually take them, and I think that is the key challenge, and really nicely fits in a 2023 era in which everything is about shared decision making. There's no doubt that drugs work, but there's now also no doubt anymore that PCI works in order to relieve angina. So I think both therapies should remain to be apparent in parallel, and should be used accordingly based on the individual patient's needs, amount of ischemia, significance of multivessel disease, effect of drugs, etc. So with that, I think interesting data, but again, a trial of which I'm not sure how this will actually change the way we currently practice medicine.
Yeah, I think the magic word here was shared decision making. You have to inform your patient that there are two treatments that work. Based on Orbita-1, we can say yes, anti-anginal therapy will work, but based on Orbita-2, PCI might even be better in terms of symptom control. And you need to inform your patient. This is what we can do for you, and now it's up to you. And I know what I would take. I would go for a PCI every day of the week. But that said, there's a lot of credit for the Orbita investigators in terms of the way they were executing Orbita-1 and now also Orbita-2. With the sham control, because really this is next level of randomized controlled study data. At the same time, I have major concerns with a 3-month endpoint. Looking at angina, I mean, it's so irrelevant. What is going on at 1 year? What is going on at 5 years? That's what you want to know. What are the hard clinical endpoints? And I'm to this day very surprised that also for Orbita-1, we do not have any written published data on what happens, what had happened with the control arm up to 1 year. And there are all kind of rumors, and I think there's even a presentation that suggested that almost all the patients in the control arm underwent a PCI or some kind of revascularization between 6 weeks and 1 year. And now here, okay, we continue. Now the primary endpoint is at 3 months, but I want to know what's going on out to 1 year and beyond that. How many of the control arm patients will end up with a revascularization? And I will give you that. It will be a lot. It will be not the minority. And this is the essence. What do we want to show here? I feel that angina can be treated medically. It definitely can be treated with a PCI. And if you really want to get rid of your symptoms in the long run, it will require eventually a revascularization. There is no doubt there. And again, shared decision making, as you mentioned, I think that is crucial. You sit down with your patient, there is no rush, but either you go for a full medical therapy, and if it fails, you can always proceed with an intervention, or you give the opportunity to get a revascularization from the get-go. And the no rush was important because no events in the 2 weeks that patients were taken off their drugs. So I mean, that's important. Absolutely. All right. Good. But an important study for sure.
Important trial.
Yeah. ECLS-Shock trial. So we mentioned that we wanted to highlight this sub-study of the ECLS-Shock because this was an important trial at the ESC, and there was a lot of debate on the inclusion-exclusion criteria. And we already mentioned in the preview that 3/4 of the patients suffered a cardiac arrest before they were randomized to the study. And obviously, the impact of cardiac arrest on the clinical outcomes was of interest. And this is the topic of this sub-study. So it was zooming in on the effects of cardiac arrest. It turns out that if they looked at the patients with cardiac arrest and compared them to the patients without cardiac arrest, there was no difference in the event rates, in the endpoints. So there was no, ECLS did not affect mortality in patients with or in patients without cardiac arrest. So basically, systematic ECLS in patients with cardiogenic shock, you should not be doing it based on this trial, not in patients who suffered a cardiac arrest, but also not in patients without the history of a cardiac arrest. At the same time, there is a safety penalty with ECLS, more vascular complications, more bleeding complications, and then on top of that, longer hospital stay, longer ICU stay. So basically, I think our takeaway in the summer is basically the same as today. There is no place for systematic ECLS. I mean, there might be an indication for escalation at one point. You treat the patient and you see that the patient is not making it. Okay, then you can consider an ECLS. It's a different story with for instance, an Impella device, which is a totally different way of mechanical support. ECLS increases the afterload. Impella decreases the afterload, and that might change the effect on cardiomechanics, and that might definitely also change the outcomes. but that needs to be studied. And those randomized controlled studies are underway. So hopefully in 2024, the latest in 2025, we will get the first data of randomized studies in that regard.
Yeah. So outcome indeed that we already anticipated a little bit. But to me, I think it's still striking. I mean, 49% mortality, irrespective of time to ROSC, irrespective of out-of-hospital cardiac arrest or not. So apparently with this device, we are at present not able to, at least on a mean scale, improve outcomes, even in a population of patients that should have had an electrate above 3. So those patients were really in shock. And yeah, the ECPR apparently was not able to improve end organ damage, and as at least when that would be reflected by all-cause mortality. So
and then that said, Joost, I think if we want to study mechanical support in the context of cardiogenic shock, we need to exclude patients with cardiac arrest. I mean, in this trial, more than 320 patients, I think 324 patients out of the 420 patients had an out-of-hospital cardiac arrest. I mean, that's a different patient population. So the call to future investigators and investigations, please exclude these patients if you want to study mechanical support in cardiogenic shock. Then we moved to 2 other trials, the ARTESiA and the SELECT trial. The ARTESiA trial was an interesting one in patients with subclinical atrial fibrillation. And subclinical atrial fibrillation was defined as atrial fibrillation for 6 minutes up to 24 hours, documented on an ICD or a pacemaker in over 4,000 patients. And these patients were at a high risk for a stroke because their CHA2DS2-VASc score was almost 4. Their mean age was 76 years old. 1/3 of the patients were women. The inclusion criteria were either age higher than 55 and a CHA2DS2-VASc score of 3 or higher, or age above 75, equal or above 75 years old, or a history of stroke. So these patients had a very high risk for stroke. Despite that high risk, the annual stroke rate was only 1% per year, which is quite low and definitely lower than anticipated. At the same time, half of the patients obviously were randomized to a full dose of Apixaban, the other half were randomized to aspirin monotherapy. Turns out that Apixaban significantly reduced the composite primary endpoint of stroke and systemic embolization with 37%. And this was significant. And there was also obviously, there were more bleedings. You can expect that. If you have more potent anticoagulant therapy, you will have more bleedings. Although the bleeding rate, the major bleeding rate of 1.7% versus 0.94% was...
in this high-risk patient cohort.
And this is manageable. And also of note, you had no excess at intracranial bleedings or life-threatening bleedings. At the same time, so this was a positive study. And basically, in contrast with the NOAA-HF NET6 trial that was also published in the New England Journal a couple of months earlier, that he looked at edoxaban in a similar patient population. That was a trial that was terminated early after an inclusion of 2,536 patients. Why terminated? Because there was a safety concern, because the composite safety endpoint of mortality and bleeding was higher in the treatment arm with edoxaban, and it was entirely driven by bleeding. There was also no effect on mortality or on stroke, whereas in ARTESiA we saw a significant reduction in stroke and also a significant reduction in all-cause mortality. So why this is? It's quite intriguing why we have a positive ARTESiA trial and a negative NOAA-HF NET6 trial. I think there is a louder and louder call for a head-to-head comparison of NOACs, in my opinion. We should have the courage to compare one NOAC with the other, because maybe it is not a class effect and it is a specific
what was the dose of edoxaban and NOAA-HF NET? You know that?
Full dose.
Full 60?
Yeah, 60.
Maybe that might be it. Huh?
But it's the same thing here. It's full dose of Apixaban.
Yeah, I know. But you saw the same in Envisage, right?
Yeah, but Envisage is a little bit of a different story, although it's a good point. Also older patients, so here the age is also close to 80. In Envisage, it was focusing exclusively on patients with aortic stenosis and treatment after aortic stenosis. But maybe we are on something there. Maybe we are over-treating these elderly patients with the full dose of edoxaban.
Yeah.
Might be, but this is another argument in favor of a head-to-head comparison, because this is an interesting finding.
And I mean the number of patients that would apply to these definitions, it's high.
Oh yeah.
So a trial would be highly relevant. I agree.
Yeah. Okay, then we have the last one. The fifth one is the SELECT trial. I thought this was quite an impressive trial. Semaglutide is a very popular drug these days, not only in medicine but also in the lay press. It's a drug that will reduce weight in patients. The trial in SELECT patients, obese patients were included without diabetes, and then the effect, and patients had a known cardiovascular disease. So they had either peripheral arterial disease or a history of coronary artery disease or stroke. Over 17,000 patients were included. The mean age was 61 years old. A quarter of the patients were women. Yeah. BMI, BMI was 33, so obese patients and no diabetes. So the hemoglobin A1C levels below 6. Also low LDL cholesterol levels, only 78 milligrams per deciliter. The primary endpoint was cardiovascular death, MI, and stroke. So the hard clinical endpoints, well, semaglutide was superior to the control arm with a 19% relative risk reduction in favor of the treatment arm, with also a trend to lower cardiovascular mortality and a significantly lower all-cause mortality. Body weight, as expected, decreased with 10% in the treatment arm. And then you always ask yourself, but okay, what about the side effects? Because we're all familiar with the GI side effects of this type of drugs. It occurred in 10%, which is manageable in my opinion.
I think so too.
And only 16% of the patients in the treatment arm interrupted the drug therapy because of side effects. So that definitely is encouraging. And I think the main takeaway of that trial is that we're talking here about the first weight management therapy that reduces cardiovascular events, and therefore weight becomes a modifiable risk factor for cardiovascular disease. And I think this is very important. So I see definitely an uptake and a higher adoption of this treatment strategy in our practice in the near future.
Yeah. So this drug is indeed a game changer, so to say. Conversely, I think it's a dilemma, right? I think it's an ethical dilemma. We now have something that can really help to improve outcomes in these patients. Whereas conversely, we also know that the key driver of this problem is diet and lifestyle, and that is a little bit the dilemma. Conversely, I think the same counts for all the therapy we have for hypertension, for instance, which is also largely driven by lifestyle, not completely, but at least to a certain extent. So interesting.
Well, definitely something when it is available and reimbursed. Definitely something to consider because it will make a difference. With that, I think we are at the end of our wrap-up of AHA 2023. We hope to see you next year for the next round of View from the Thoraxcenter for Radcliffe Cardiology. Thank you for staying with us.
Thank you. Bye-bye.